Good evening, ma'am. Ma'am, you are likely on mute. We cannot hear anything.
Hello. Yeah. So I was talking to you regarding the epidemiology of the chronic kidney disease. And if you look at the epidemiology from European and from the Middle East and Southeast Asia, the incidence from the European population is around 11 to 12 per million child population, whereas it is at least 3 times higher in Southeast Asia and Middle East. And specifically in Middle East, the numbers are higher probably because of more structural abnormalities, because of consanguinity in these particular areas. And if you look at the male to female ratio of chronic kidney disease, it is much higher in males as compared to females. And this is probably because of higher incidence of posterior urethral valve, obstructive uropathies, etc. in males. My screen is not moving. Hello. Hello. My screen is not moving. Hello, am I audible?
Yes, ma'am.
Am I audible now?
Yes, ma'am.
Hello. So I was just talking about the epidemiology of chronic kidney disease, that we have a higher incidence in Middle East and Southeast Asia as compared to the European population, and probably this is because of the consanguinity. Now, if you look at the data of chronic kidney disease, the availability of data is primarily from various renal registries, and we have this North American Pediatric Renal Transplant and Cooperative Society Registry data, we have the Australia and New Zealand data, and we have our own CKD registry of India. And if you look at most of these registries, they were started in transplant patients, then they were expanded to patients who were on dialysis, and now they have also started recording data from patients who have non-dialysis patients, that is patients in CKD stage 2 and stage 3. And if you look at the data from most of these registries, and it is primarily on transplants and primarily on those who are on dialysis. Now, if you look at the causes of chronic kidney disease from these registries, you'll find that most of these patients have an underlying structural abnormalities, that is congenital anomalies of kidney and urinary tract, and which constitutes to about 40 to 50% of the various populations, followed by chronic glomerulonephritis, followed by tubular interstitial diseases, chronic pyelonephritis, and many other diseases like renal stones, tubulopathies, etc. Now, this is a recent study from Germany where they looked at 405 patients who presented with congenital anomalies. And what they found was that renal hypoplasia dysplasia is the one of the most common abnormality, which constitutes in about two-thirds of the population. And almost half of these are antenatally detected. And the stages of CKD presenting in boys is much worse than those who are, especially in those with females. And if you look at the symptoms of chronic kidney disease, most symptoms of CKD develop once the GFR falls below 30 ml. Once the GFR is above 45 ml, most patients are asymptomatic, and that is one of the primary reasons why the patients do not present early, and most of them present in later stages of CKD in the pediatric population. And if you look at the complications of chronic kidney disease like anemia, metabolic acidosis, bone mineral disease, they usually present once the GFR falls below 30 ml. And similarly, symptoms like nausea, vomiting, gastritis, and hypertension present in CKD stage 4, that is a GFR below 15 ml. And once the GFR falls below 10 ml, they start developing edema, CHF, polyneuropathy, and mental changes. So if you look at, this is the data from the CKD registry of pediatric of India, the pediatrics registry, and this is our own contribution from our own side. And if you look at the most common presenting features in these patients were essentially edema, failure to thrive, and acidosis, and most of them had presented in late stages of CKD, that is CKD stage 4 and stage 5. Now, if you look at the investigations that one needs to do in patients of CKD, well, we need to do a hemogram to identify anemia. We need to do a KFT to identify the stage of CKD. Then we know that various electrolytic abnormalities like hyperkalemia, hyponatremia, hypocalcemia, hyperphosphatemia can occur in these patients. So all these investigations are required. And a venous blood gas is required to identify the metabolic acidosis. And for identifying the bone mineral disease, the calcium phosphate, alkaline phosphate, and PTH values, and 25-hydroxy D levels essentially to identify any other underlying vitamin D deficiency. A urine protein microscopy is essentially required to detect the proteinuria. And for quantification of proteinuria, it has to be either a 24 hours protein estimation or a spot albumin creatinine ratio. Other parameters like 24 hours calcium, oxalates, citrates are only required if there is urolithiasis. Now, amongst the imaging, the most important imaging in a child of CKD is probably an ultrasound abdomen, which gives us enough idea of the abnormalities, underlying abnormalities. Micturating cystourethrogram, I'll be showing you some of these pictures where some of these patients are having these underlying abnormalities. MCOG would help you in detecting the lower tract abnormalities like posterior urethral valve, or bladder, obstructive uropathy, etc. Intravenous pyelogram is rarely done in today's era. Most of the IVPs have now been replaced by nuclear scans like your DTPS scan, which is a functional scan and which can tell you the functionality of the kidney. Apart from that, other scans like DNSA scans, the dimercaptosuccinic acid scan helps in identifying the structural anatomy of the kidney and helps in also identifying any visualizing any scars which are present in pyelonephritic kidneys. Now, CT scans are rarely done in patients of CKD, but only in situations where, if you're suspecting calculi and small calculi are often not detected on ultrasound, in such a situation, you can do an NCCT CT. Because in most CT scans, you need to give contrast. And on a patient who has already an underlying CKD, you would avoid using the contrast agents for preventing any further damage to the kidneys. Now, MRI is another modality which helps in detection of any cystic renal diseases, and it also helps in identifying the total renal volume. Renal biopsy is indicated only if we are not able to detect any abnormality in the kidneys look relatively normal, or if there is a significant proteinuria which is persisting for prolonged periods. In this situation, probably a renal biopsy will help in identifying the cause of chronic kidney disease. Now, in the present era, genetics for especially polycystin 1 and polycystin 2 gene for identifying any autosomal recessive polycystic kidney disease or any autosomal dominant polycystic kidneys is often done to identify patients. And then you have the nephronophthisis panel, which is usually done by next generation sequencing. So to identify the cause of chronic kidney disease. If you look at the utility of ultrasound, what all you need to really look at the ultrasound to identify an underlying chronic kidney disease. The size and shape of the kidneys is important. If they are small kidneys which are echogenic, and if you find that there is a dilated collective system, then it often goes in favor of a dilated system like PUG obstruction or a VUR or an obstructive uropathy, etc. Then another important parameter is your anterior posterior pelvic diameter, which helps in identifying any dilatation, any renal dilatation. Apart from that, urinary bladder wall thickness is an equally important thing, because if a patient has a posterior uropathy or an obstructive uropathy, then in that situation the bladder wall thickness would be there. The normal bladder wall thickness is around 2 to 3 millimeters. And on an ultrasound, you can even detect any post-void residue urinary volume. If your bladder is detected, definitely even after micturition, there will be a significant amount of urine which is actually there in the bladder. So if you find that even this is an abnormal bladder, which may predispose to CKD. Now, if you look at the dilatation, this is a ultrasound of a kidney, and you can see that there is a dilatation in the pelvis, and you can also see the dilated calyces, and you can see a dilated ureter. Normally, on an ultrasound, you cannot visualize the ureter. If you are visualizing a ureter on a kidney, then that on the ultrasound of the kidney, that implies that the patient is having a dilated system. Either it is a posterior urethral valve or it is a VUR. Now, if you look at, this is again a dilated anteroposterior pelvic diameter, and you can see that there is a dilatation, there is an APPT that is dilated. Now, this is how a DTPA scan would look, and just I'm not going into the details of this, but you can see that one kidney is looking more dilated as compared to the other. There is more dye uptake in one kidney as compared to the other kidney. So these are the parameters which can use to identify whether the kidney is concentrating the dye, whether it is functionally normal or not. So DTPA scan is often used for identifying the residual renal functions of patients in CKD, but it should not be used in advanced stages of CKD like CKD 4 and 5, because in these situations it may not, if the kidneys are very defective, then they will not concentrate the dye at all. This is another DTPA scan. So this is just to show you that only one kidney is there, the other kidney is missing in the other renal fossa. So often, when you are not able to identify the kidneys on the ultrasound, in order to identify whether it is actually there in the pelvis or lying somewhere else, or it is actually absent, a DTPA scan really helps you to identify the kidney even in various abnormal locations. Now, micturating cystourethrogram is often done to identify the degree of vesico-ureteric reflux, where in the VUR, what is really happening is that the urine is, your vesico-ureteric, valve is defective, and because of that, the urine goes up and it goes up to the kidney. In lower grades of reflux, there is not much dilatation in the kidney. of the pelvis. But in higher grades of reflux, that is grade 4 and grade 5, you can find that the pelvis is grossly dilated, and so are the calyces, and there are tortuous and dilated ureters. Now, this is the MCU of a 2-year-old girl who presented to us with recurrent episodes of UTI. And when we did the MCUG, we found that the bladder is very bad. It is heavily trabeculated, and you can see that both the ureters are grossly dilated with the dilated pelvis and dilated kidney. So, this is a case of primary secondary vesicoureteric reflux where there is a neurogenic bladder. This is another MCUG which is showing a erythropoetin within the bladder, a grossly dilated bladder in an infant, and you can also see some reflux. You can see a lot of reflux of the dye into the ureters, and the ureters are quite dilated and a little tortuous as well. Now, if you look at this MCUG, you can see that the posterior urethra is dilated and the bladder is also heavily trabeculated, and there is a reflux indicating that this is a child who has posterior urethral valves. So that is the utility of MCUG, that it helps you in identifying the lower tract abnormalities. So what are the complications of chronic kidney disease? I'll be going through each of these individual complications. So the common ones being anemia, hypertension, metabolic acidosis, bone mineral disease, and growth failure. Now, if you look at the epidemiology of anemia, almost all patients with chronic kidney disease in higher stages of chronic kidney disease will have anemia. And the definition of anemia, as we see in children, it is less than 11 grams per deciliter in any of the age groups. In older age groups, you take even cutoffs of 12 and 13. Now, the causes of anemia in children with chronic kidney disease are essentially iron deficiency, erythropoetin deficiency. Chronic kidney disease is also considered as a process of an ongoing inflammation, and so anemia of chronic inflammation can also cause anemia in these patients. And there occurs chronic blood loss in these patients during hemodialysis. And presence of concomitant vitamin deficiencies like B12 and folate, primarily because of dietary deficiencies, because of anorexia and all, can also result in anemia. So to identify iron deficiency in these patients, which can be absolute or functional. Now, absolute iron deficiency essentially occurs because of sampling, blood loss, and even a reduced RBC lifespan. On a uremic milieu, the RBC lifespan is reduced from 120 days to about 90 to 100 days. And apart from that, there is functional abnormality as well, which results in disturbances of iron metabolism in chronic kidney disease, which leads to lower transferrin levels. Hence, there is a problem not only in iron absorption, but also in iron transport. Now, if you look at the evaluation that you need to do for anemia is that you need to look at the complete blood count with the RBC indices, and absolute retic count will help you to identify iron deficiency, and serum ferritin levels are very important to identify any concomitant iron deficiency in these patients, and B12 and folate levels will also additionally identify any concomitant B12 and folate deficiency. Now, if these patients are iron deficient, we need to maintain their irons above serum ferritins of more than 100 nanograms per ml and a transferrin saturation of more than 20%. And all pediatric patients with CKD should be started on oral iron. IV iron is required only in patients who are undergoing hemodialysis. Now, another important component of treatment of anemia in pediatric CKD is the use of erythropoetin. As we know that as the kidney function fails, there occurs a erythropoetin deficiency, and therefore you have to supplement erythropoetin exogenously. If you look at the data from United States, almost half of the patients, even prior to dialysis, are already on erythropoetin, and almost 100% are on erythropoetin when they are being dialyzed. But if you look at our own CKD registry, roughly about 10% the usage of erythropoetin is as low as 10%, and this is primarily because of the cost of erythropoetin. Now, if you look at the guideline, the recommendations of the use of erythropoetin, it should be started at any time when your HB falls below 10. And you need to start it at doses of 20 to 50 international units per kg, and it can be given as 2 subcutaneous doses each week. And lately, another congener of erythropoetin is available, which is a long-acting congener and which needs to be given only 2 times a month. So most centers have shifted to darbepoetin therapy, especially in older children. And once the patient is on erythropoetin and oral iron, the iron status should be monitored every 3 months, and those modifications should be done only not before 2 weeks. and the target hemoglobin for these patients is 11 to 12 grams per deciliter. A word about metabolic acidosis. Now, serum bicarb is maintained between 22 to 25 milliequivalents per liter, and roughly 1 milliequivalent per kg of acid is generated by the metabolism in the body. And most patients would develop metabolic acidosis once the GFR falls below 25%. So why are we so bothered about this metabolic acidosis? Well, this chronic metabolic acidosis can lead to muscle wasting, decreased albumin synthesis, and impaired growth. Now, the aim of giving bicarb in these patients is to maintain a bicarb value of more than 22 milliequivalents per liter, and oral supplementations are available both as powder, syrup, as well as tablets, and we need to treat the acidosis that is associated with chronic kidney disease. Now, what about bone mineral disease? Now, earlier it used to be called as renal osteodystrophy, but we don't use the term renal osteodystrophy anymore. It is now called as chronic kidney disease, and this basically it is the bone mineral disease of CKD is defined as either one of the following or a combination of the following, and these are mainly an abnormality of calcium, phosphate, PTH, or vitamin D metabolism, or an abnormality in bone turnover, mineralization, or strength, or any vascular or soft tissue calcification. Now, the bone lesion, the primary reason for the bone lesions in these patients is an excessive PTH, and this primarily occurs because of your inadequate excretion of phosphates from the body. There occurs hyperphosphatemia. Apart from that, once your phosphates rises, the calcium also tends to get decreased, and this is a major trigger for your PTH. And because of the excessive PTH, it leads to bone resorption from the bones, and it may lead to osteoplastic bone changes in these patients. And apart from this, there is also a deficiency of vitamin D, because you know that 1-alpha hydroxylation occurs in the kidney, and as the kidney function is lost, this hydroxylation of active form of conversion to active form of vitamin D is lost over a progressive period of time, which leads to a poor absorption of calcium and a poor assimilation of calcium in the body, resulting in defective mineralization. And in children, this can lead to bad rickets, and it contributes majorly to the growth failure that occurs in CKD. And if you use too much of vitamin D and oversuppress the PTH, then what results is your adynamic bone disease, which can also contribute to growth failure. So what is the workup that is required for these patients with bone mineral disease? Essentially, you need to look at their calcium, phosphate, and ELP values, their PTH values, and a 25 hydroxy D levels to identify any concomitant vitamin D deficiency. X-ray of pelvis and a wrist with hand is very required to identify the renal osteodystrophy as well as rickets. And it is recommended that these investigations should be done at least annually in early stages of CKD, that is CKD up to stage 3, and beyond in stage 4 and stage 5, they should be done every 3 to 6 months. So what is the treatment for this bone mineral disease? If your biochemical parameters are normal and if there is no growth failure and there are no signs of rickets, no treatment is required in early stages of CKD. Once vitamin D deficiency starts setting in, you need to supplement these patients with vitamin D, and you can use cholecalciferol for on weekly doses for about 10 weeks period. But if you have high phosphates, low calcium, and your SAP and PTH are also high, then which usually happens in patients who have CKD 3, 4, and 5, in such a situation, you need to do dietary restriction of phosphate, you need to use phosphate binders, and you can use active forms of vitamin D like alpha hydroxy D and 125 hydroxy D to suppress your PTH. Some of the phosphate binders that we use in pediatric population are mostly calcium based, and these are your acetate and carbonate based binders. And although calcium acetate binds much higher phosphate as compared to calcium carbonate, but still the cost of calcium carbonate is much lower as compared to acetate. So we use calcium carbonate as the most reasonable phosphate binder in our population. And apart from that, now we have non-calcium containing binders also like sevelamer, which we usually prefer in patients if their serum calcium levels are normal. And vitamin D analogs like 1-alpha hydroxy D and 125 hydroxy D or calcitriol can be used for suppressing your PTH values. Now, the target PTH values usually in the early stages of CKD are normal values of PTH, but in stage 4 and stage 5, you don't want to suppress it too much also because that would predispose to a dynamic bone disease. So, you want to maintain it at around 5 to 6 times of the upper limit of normal. Now, the growth failure, which primarily occurs in chronic kidney disease, is essentially occurs because of the poor appetite, which occurs because of anorexia, concomitant anemia, acidosis, hyperparathyroidism, increased protein metabolism due to metabolic acidosis, and also there is a situation of apparent GH resistance on a background of uremic mania. And in our population, we have seen that more than 50% of our patients who are attending our clinics actually have a secondary malnutrition. So the parameters that need to be evaluated to identify this malnutrition are your dietary intake records. Ideally, it should be a 3-day record, but in a busy clinic, it is difficult to do a 3-day dietary record. So sometimes we just do a 24 hours dietary records for these patients. And an anthropometry is a very important way of looking at their growth failure. That is the age, appropriate weight, height. The weight for height needs to be monitored for these patients, and it should be done at least semi-annually in all patients of chronic kidney disease. And in those patients who have severe growth retardation, they can be done even every 3 months. And all these patients would require good dietary counseling by the dietitian, and it needs to be checked during each OPD visit also whether they are taking adequate calories and proteins or not. Now, it is important to give all these patients 100% of their RDA for if they are not malnourished. But if they are malnourished, they will require much higher calories, and they would also require a higher amount of protein. Now, if you talk about the adult CKD, the moment we hear the word CKD, we need to say that we need to restrict proteins in these patients for progressing these stages or preventing the progression of CKD. However, there is no role of dietary protein restriction in pediatric CKD because the growth failure may occur. And most patients who are on hemodialysis and peritoneal dialysis, in fact, need actually much higher amounts of proteins as they are losing proteins in both hemodialysis as well as peritoneal dialysis tubes. Now, regarding a word about vitamins and minerals, you just need to give them the normal RDA for their vitamins and minerals. Mega supplements should be avoided because your kidneys are not excreting them in larger amounts, and that may lead to that may precipitate toxicity. A word about potassium and sodium. Now, potassium tends to increase once the patient is in CKD 4 and 5. So, there is no point in restricting potassium in the diet in the early stages of CKD. And similarly for sodium, if the patient is hypertensive, only then there is a role of restricting sodium. Otherwise, reduced sodium diet in pediatric age group can lead to non-palatability, and therefore the child may actually refuse to take the diet. But it is important to avoid things like which have high amounts of sodiums like chips, salty biscuits, etc. So that advice can be given to these patients. Now, hypertension, I'll be discussing about this in detail, but in the later slides. But if you look at the overall CKD, almost 50% of these children have hypertension, and both the high blood pressures as well as increased proteinurias are predictors of progression of CKD in pediatric population. So it is suggested that antihypertensives should be started once the BPs are more than 90th centile for these patients for that age, gender, and height. And the antihypertensives that are preferred for preventing the progression is that if the patient is having significant proteinuria, then there is a point in starting ACE or ARBs. But ACE and ARBs should be given carefully. They should not be given to patients who have a GFR below 30 ml because this can cause significant hyperkalemia. The other antihypertensives which we can safely use in these patients are calcium channel blockers, amlodipine, beta blockers like atenolol and metoprolol, alpha blockers like prazosin, clonidine, diuretics, etc. can be used safely in these patients. Now, very briefly, I'll talk to you about the kidney replacement therapy because renal transplant, though, is the most definitive and best form of kidney replacement therapy, but most patients would require dialysis in some form, either in the form of peritoneal dialysis or hemodialysis before they go to this stage. So the indications of starting kidney replacement therapy in chronic kidney disease are when your GFR falls below 10 ml, or if there is medically uncontrolled hyperkalemia, fluid overload, uncontrolled hypertension, or an increasing hyperphosphatemia, uremic symptoms, or there is persistent growth failure. even at higher GFRs, you can start kidney replacement therapy if there is persistent growth failure. The modalities of kidney replacement therapy are peritoneal dialysis and hemodialysis. If you look at the current scenario of the use of these modalities in the pediatric age group, if you look at the American data, a larger number of patients are on chronic peritoneal dialysis. But if you look at the Indian data, a larger proportion of patients are on hemodialysis. The reason for this being that hemodialysis is available at tertiary care centers, and it is, like it is in, at least in the government setup, it is available free of cost. Whereas chronic peritoneal dialysis is not supported by the government in India. So because of that, the older children, most of the families tend to prefer hemodialysis as compared to peritoneal dialysis. But if you ask me regarding the utility of each modality, in younger age groups, it is difficult to achieve vascular access and all, and hemodialysis leads to more complications in younger population. And that is why in children below the age of 5 to 6 years, we prefer chronic peritoneal dialysis as one of the kidney replacement modalities. Whereas in older children, especially above 7 to 8 years of age, hemodialysis is a preferred modality. If you look at the principles of dialysis, they are almost same for both these modalities. Now, dialyzer is the peritoneal membrane in case of peritoneal dialysis, whereas it's an artificial membrane in case of hemodialysis. And the major way of removing the solutes is basically by passive diffusion, which is passive movement of solutes across a concentration gradient. And by the osmotic ultrafiltration or convection, we are removing the fluid. So we need to remove the urea, creatinine, sodium, and potassium by diffusion, whereas we need to remove the fluids by use of osmotic ultrafiltration. And the osmotic ultrafiltration in peritoneal dialysis is essentially the glucose that is added to the dialysate fluid, whereas in in hemodialysis, it is the hydraulic pressure or the transmembrane pressure which is being provided by the hemodialysis machine. Now, if you look at the delivery of peritoneal dialysis in the pediatric age group, it can be either manual, but most children are unable to do the peritoneal dialysis themselves. So the parents will have, or the caregivers will have to do the peritoneal dialysis. And now many of these automated cyclers are available, which help in doing the automatic peritoneal dialysis, especially during night time. So that can give some relief to the primary caregivers, because otherwise the parental burnout happens much earlier in patients with chronic peritoneal dialysis in pediatric age group as compared to hemodialysis. And if you look at the types of, I'm not going into the details, but you need to know the names. Like chronic ambulatory peritoneal dialysis, we do at least 3 exchanges during the day and 1 long exchange in the night, so that both the caregivers and the patient can sleep properly in the night. On the other hand, if the child wants to attend school or college during the daytime, then it can be a long dwell during the daytime, followed by nightly peritoneal dialysis or nightly intermittent many doses, and which can be given in the form of cyclers. Now, for peritoneal dialysis, you essentially need a permanent double cuff catheter, which is your 10 cuff catheter, which needs to be placed surgically, which can be done by an open surgery or laparoscopically. And this is a typical CAPD prescription where the nephrologist will have to give the number of cycles, the amount of dwell time the fluid is going to stay inside the abdominal cavity, and the total dwell volume that needs to be put into the abdominal cavity, and the type of peritoneal dialysis solution that should be used for doing this peritoneal dialysis. Now, for hemodialysis, you essentially need a hemodialysis machine, you need a vascular access, you need to use a appropriate dialyzer size with pediatric tubings, the dialysate concentrate, and you need, because it's an extracorporeal way of doing a procedure, you need to use an anticoagulant like heparin during the procedure of hemodialysis. And for most patients, 3 to 4 hemodialysis sessions are done every week for a period of 3 to 4 hours. So the total dialysis dose for any patient is usually 10 to 12 hours of dialysis per week. And you definitely need a trained manpower like a dialysis technician and a dialysis nurse. So this is an ongoing session of pediatric hemodialysis, and this is the vascular access, which is a double lumen hemodialysis catheter which has been inserted into the femoral vein. And this is the dialysis machine, and this is the dialyzer, which is a hollow fiber type dialyzer. And from one port the blood is going into the dialyzer, and from the other and the dialysis fluid which is being done through the one side of the dialyzer is being put across through it, and there are two, you have this this is the blood pump, and the blood is being pumped into the dialyzer, and subsequently as it is being cleaned, both the electrolytes and the extra urea, creatine, etc. gets removed and it goes back, whereas this blood, the clean blood can again be put back into the body through the same vascular access. And this is a typical hollow fiber dialyzer with pediatric tubings, and the dialyzer is different for different age groups. And essentially you choose a dialyzer by the surface area of the child. You need to use a dialyzer which has a surface area of about 75% of the patient's body. And if you look at the site of putting the this is a typical double lumen hemodialysis catheter, which can be inserted either into the femoral vein, into the internal jugular vein, or into the subclavian vein. In older children, you can have arteriovenous fistulas, you can have arteriovenous grafts also. But the most preferred site is your internal jugular vein, because this tends to get infected the least, and the catheter tends to stay for longer periods of time, and you can do prolonged dialysis but for even up to 3 to 6 months by putting in a single catheter. And the choice of catheter size is based on the weight of the patient. Now, what about kidney transplant? The first adult successful kidney transplant was done in 1954, and this was between two identical twins. Subsequently, the first pediatric renal transplant was done somewhere in 1970s. And after that, since 1980s, it is being done in most Indian centers as well. And if you look at the immunosuppressants that are used after pediatric renal transplant, they used to be prednisolone, cyclosporin, and azathioprine till about 10 years back, and now it has been converted to prednisolone, tacrolimus, and mycophenolate mofetil in the last 5 years. So the basics of renal transplant are that you need a blood group matched and HLA matched donor for children, and so therefore most parents qualify as donors, and the age of the donor should be between 18 to 65 years, and the donor should not be suffering from diabetes or chronic illnesses, Hep B, Hep C, HIV, or malignancy, etc. And if you are using a deceased donor, that is a cadaveric donor, then it is only a blood group match that is really required. So you need a donor and recipient, detailed donor and recipient evaluation prior to surgery. If you look at the published data of pediatric renal transplants from India, from centers in India versus the North American Pediatric Renal Transplant Cooperative Society annual report, and looking at this sheer number, you can see that many pediatric CKD patients do not get transplanted in our country. Look at the numbers, 10,632 versus 116, 33, 90, 39 being done at each of these centers during almost the same period. But if you look at the profile of the donors, in our series, most of the times it has been the live related donors. And out of these live related donors also, most of the time it has been one of the parents and mostly the mothers. But if you look at the long-term survival of these data, it is almost similar to Western data. If you look at the 10-year survival of renal graft, it is around 90% in almost at all of our centers, except for this one series from SGBGI, where patients, because of the non-affordance of immunosuppressants, had actually stopped their immunosuppressants, cyclosporin and MMF, etc., post-transplant, and that resulted in chronic rejection. And that is one of the reasons why the long-term survival was low in this particular series of published data. Now, if you look at the cost of kidney replacement therapy for a roughly 20 kg child, the cost is much lower in the long run with a renal transplant. And if you need to do dialysis with erythropoetin, with supplements, it is almost 30,000 per month, for both hemodialysis as well as peritoneal dialysis. But if you do hemodialysis in government centers, obviously it is free of cost. But yes, if in a private center, each hemodialysis session costs roughly anywhere between 5,000 to 8,000 per session. So it turns out to be very expensive. So the best thing probably is, and children also on hemodialysis or peritoneal dialysis do not live very long, not more than 1 to 2 years. So that is why it is important that once they reach that stage, the dialysis modality should only be used as a stopgap arrangement to go ahead with a transplant. Only then it has its utility. So after going to CKD, I'll briefly talk to you about pediatric hypertension. Now, if you look at the, there has been a change in the definition of pediatric hypertension, and these new guidelines were published in 2017. And according to this, according to these new definitions, in children below the age of 13 years, that is between 1 to 13 years, elevated BP is defined as any blood pressure between 90th to 95th centile for that age, height, and gender. And BP is less than 90th centile for age, height, and gender are considered to be normal. And stage 1 hypertension is any blood pressure which is more than 95th centile, and more than 95th centile plus 12 constitutes your stage 2 hypertension. And in children beyond the age of 13 years, it is almost similar to adults. Your normal BPs are less than 120/80, and BPs, systolic BPs up to 130, and diastolic BP less than 80 constitutes your elevated blood pressure. And stage 1 hypertension is anywhere between 130 to 139 and 80 to 89 millimeters of mercury of blood pressure, and any BP of more than 140/90 in any pediatric age group constitutes stage 2 hypertension. Now, if you look at the epidemiology of hypertension, while almost 30% of all adults above 30 years of age are hypertensive, the incidence of hypertension in children is much lower, but still it is 3.5% in children of all ages, and another 10% have elevated blood pressure. And there has been a recent trend in the change in the last 10 years or 20 years. There has been a significant increase in the incidence of hypertension, and this appears to be primarily related to obesity. There has been an increase in the incidence of obesity from 0.9% in 1975 to almost 7.8% in 2016. And if you look at the patients who are obese, almost 1/4 of them are also hypertensive. Now, if you look at, these are some of the new charts which are much easier to use to identify whether the patient is hypertensive or not. So to use these charts, you just need to know the age of the child. So if it's a 1-year-old child, and if his height is 80.80, around 80 centimeters, then his 50th centile for the BP, systolic BP is 86 millimeters, 90th centile is 99, 95th is 103, and 95 plus 12 is 150. So by using these charts, because blood pressure, elevated blood pressures or hypertension, the diagnosis is based both on systolic or diastolic, or either on systolic or diastolic BPs. So you have these for both systolic as well as diastolic BPs. So these are charts which are much easier to use as compared to the previous charts. Now, what about what constitutes hypertension in neonates and infants? Because these charts can be used only beyond 1 year of age. In neonates, the incidence of hypertension is less than 3%, but in high-risk newborns, it is much higher. It is about 9%. And the BP values, you have separate charts for babies who are born with between 26 to 44 weeks. And between 1 month to 1 year of age, you are supposed to use the second task force curves only. I'll just give you a snapshot of that. Now, this is a BP chart for infants, that is from birth to 30 days, and here you can use the post-conceptional age. So if it's a newborn born at 40 weeks, if you look at the 50th centile BPs, they are 80/50, and this increases to 95/65 if you look at the 95th centile, and BPs of 100/70 are more than 99 centile for newborn babies. So one child is born with the lowest BPs, and these BPs keep increasing to, and they reach to normative values as those of adults around 13 years of age. Now, if you look at, these are some of the charts. These are the second task force curves which need to be used between, if you are looking at children, you are comparing the BPs of children between 1 month of age till 1 year of age, and you can look at, they give you the values of 50th, 75th, 90th, and 95th centiles. So what are the devices that you should be using for BP measurement? Now, earlier we were using a mercury sphygmomanometer, but we know that because of the environmental hazard that mercury used to cause, now we don't use mercury sphygmomanometers, but you have these mechanical sphygmomanometers that are now available. Then you have these automatic devices which are based on oscillometric method, where you don't auscultate, they give an automatic value, but this is a calculated values of systolic and diastolic BP from the oscillations that occur in the vessel over which the cuff is lying. So these values are less reliable. Then you have the aneroid devices, where you can use a stethoscope to measure the blood pressures. Now, in pediatric wards, you will find that there are multiple sizes of these pediatric cuffs. These are essentially because across different ages, you need to use a cuff of appropriate size, because a large cuff will underestimate the blood pressure and a smaller cuff will overestimate the blood pressures. So the way the ideal BP cuff should be having a cuff width of about 40% of your mid-arm circumference, and the length should be between 80 to 100% of the mid-arm circumference. So if you don't remember your mnemonics that what size cuff that you need to use in a particular child, you can measure the mid-arm circumference and you take a 40% of that value, and the width of your cuff should be around 40%. So the recommended devices and the method of measuring blood pressure is your auscultatory method with the use of a sphygmomanometer. And oscillometric methods are essentially used for screening of hypertension in busy OPDs, but confirmation should always be done by auscultatory method. Now, if you look at the various widths which of cuffs which are available in the pediatric wards, you have the 4 centimeter width for a newborn, 6 to 7 centimeter for an infant, 9 to 10 centimeter for a child, and you can use adult sized cuff for children beyond the age of 13 years. But when you want to measure the all four limb blood pressures, in that situation you will need to use large adult cuffs as thigh cuffs also, because thigh cuffs are larger in size. So who should be screened for hypertension? The Indian Academy of Pediatrics recommends that all children beyond the age of 3 years should have annual BP measurements. And it should be done at each healthcare encounter if the child is obese, is having an underlying chronic kidney disease or diabetes, or if there is an underlying history of any underlying heart disease. And in high risk groups, that is babies that were born preterm with various, and they stayed in nursery, had an underlying heart surgery, have underlying acyanotic or cyanotic CHD. Now, if you look at the common causes of hypertension in the pediatric age group, renal parenchymal diseases like chronic GN, acute GN, reflux nephropathy, obstructive uropathy, polycystic kidney disease, etc., constitute the most common cause of of pediatric secondary hypertension. In fact, renal parenchymal and renovascular diseases constitute roughly 2/3 of all pediatric secondary hypertension. Rarely you may see a patient landing up with coarctation of aorta, which may be the cause of hypertension. Then again, endocrine causes of hypertension like pheochromocytoma, Cushing syndrome, primary hyperaldosteronism, congenital adrenal hyperplasia are rather rare causes of hypertension. And Wilms tumors and neuroblastoma, etc., again may constitute. So all these causes will constitute less than 5% of pediatric hypertension. And once we have ruled out all these conditions, then probably if you are not able to figure out cause, then it is probably essential hypertension and early onset of essential hypertension. But generally, less than 10 years of age, you won't see essential hypertension. Less than 10 years of age, these are the causes of hypertension. Beyond 10 years, possibly, if the child has presented for the first time, then essential hypertension may be a major cause of hypertension. So before going to the evaluation, I would just like to say that most of these patients of hypertension, like in adults, may present with history of sleep abnormalities, headache, and sometimes, if they have pheochromocytoma or an extra adrenergic surge, they may complain of palpitation. But in most situations, hypertension goes as in adults, without any symptoms. So most of them may not have any symptoms. They may have symptoms related to underlying renal disease like swelling, hematuria, or proteinuria, etc. And from that, you can figure out that possibly the underlying cause is a renal disease. So all patients who have hypertension should undergo a urinalysis, not just for protein and sugar, but also for microscopy to look at any RBCs or WBCs, whether the child is a case of acute glomerulonephritis or having stones, etc. So this can be detected with the help of a urinalysis. Then in a chemistry panel would include your electrolytes, KFT, etc. A fasting lipid profile should also be done, especially for patients who who are obese or overweight. And a renal ultrasound should be done for all children who present with hypertension to identify any structural abnormalities of the kidney. HB1AC is usually indicated in obese patients, and especially in ALT-AST2, again in obese patients. And thyroid stimulating hormones, if all of these things are negative, then rarely hyperthyroidism may also cause hypertension. And sleep studies, etc., generally only as secondary causes if the child is very obese. Now, for identifying renovascular hypertension, there are a Doppler ultrasonography is a good screening modality where you can look at the renal resistive index of the main renal arteries or interlobar or aquate arteries. Well, earlier we used to use a lot of CT angiography, which has a high sensitivity and specificity to identify renal artery stenosis. But in the era of MR angiography, we don't want to expose these young children to a lot of radiation, so that is why we would go ahead with an MR angiography. And nuclear radiography generally is not required for identifying the cause of hypertension, but in patients who have recurrent UTI, sometimes we go ahead with a DMSS scan to identify renal scars. So why are we so bothered about this pediatric hypertension? We are bothered about the target organ damage. And especially, to the heart. Silent hypertension, we know, is a killer. So to identify the target organ damage to the heart, that is the left ventricular hypertrophy, and echo is the best modality. ECG is relatively has a poor sensitivity to identify moderate to severe left ventricular hypertrophy, and various parameters like left ventricular mass, the left ventricular relative wall thickness, and ejection fraction are looked in a good echo to identify any target organ damage because of the preceding hypertension. And besides the echo, even in the eye evaluation, you can see hypertensive changes in the retina. So an eye ophthalmological examination is also recommended for these patients to identify any significant hypertension in the past. And regarding the management of hypertension, for elevated BP, it is recommended that we should start with a DASH diet. So DASH diet is basically dietary approaches to stop hypertension, and a major component of DASH diet is essentially a low sodium and high potassium diet. And most of this diet would constitute of fresh fruits, vegetables, less amounts of fats, etc. And you start these dietary modifications and encourage the child to increase his activity, become less of a couch potato, to lose weight, and then you can reassess the child at the end of 6 to 12 months. If the blood pressures are still on the higher side, then it is recommended that you should be doing an ambulatory BP monitors. And if the BPs are still high, despite all your evaluation, diagnostic evaluation, then you should start with some form of pharmacotherapy. But if the patient presents in asymptomatic stage 1, lifestyle changes, etc., should be recommended only if the patient does not have underlying renal parenchymal abnormalities or renovascular